This is the continuation in the pain management series. Today, we are going to talk about the mechanisms of opioid-induced analgesia. All, this is Dr. Mubin Sayed. Welcome to one more talk. This is a talk that is the continuation in the pain management series. Today, we are going to talk about the mechanisms of opioid-induced analgesia at the supraspinal level, at the spinal cord level, and at the peripheral nerve level. I have no disclaimers, and let's start our discussion. So the primary reference textbook today is the Goodman-Gilman 13th edition, and I believe page number 1376. So the question is analgesia produced by opioids. Of course, the clinical benefit of understanding this is that you understand which parts of our tissues respond to opioids and what happens to them, or what happens when opioid is acting there. And then especially when we give the opioid antagonists, what are the parts where they work? And similarly, when we talk about withdrawals and substance abuse disorder, these mechanisms would help us understand more. So let's start. So first of all, opioid agonists have their action at three levels. Supraspinal level, that will mean brain, brainstem, these tissues. Spinal level, of course, that would mean within the spinal cord. And then the peripheral nerve level, that would mean the peripheral nerve itself or the nerve endings, wherever they end, or even the immune cells that are surrounding a nerve ending or a nerve. That all will be peripheral nerve. Why do we say immune cells that are surrounding the nerve and the nerve ending and the nerve? Because majority of these mechanisms, some of them are known, and some we are actually not clear. For especially the peripheral nerve effects of opioids are not clear to us. So is the effect produced because of the opioids action on the nerve, or is it produced because of their action on the immune cells, for example? We are not clear. So let's start. So first of all, supraspinal opioid analgesia. That means the opioid produced pain-killing or analgesic effect above the spinal cord. Now, above the spinal cord, there is brainstem and cerebellum and the limbic system and hypothalamus and thalamus and then cortex. So there are many, many structures. It is interesting that they have separated various structures, and when they put opioid on them, many times that causes analgesia to be produced. That means there are lots of areas of the brain that respond to, for example, mu receptor, that have mu receptors of the opioid system or for opioids, and they respond with analgesia. However, an important and the most characteristics of the opioid activity is the area that is around the aqueduct in the midbrain or mesencephalon. So that area is called the periaqueductal gray matter of the mesencephalon, or PAG region, mesencephalic PAG. That is what we are going to talk about. So many areas of the brain produce analgesia when morphine is injected in them. Naloxone can reverse it. So please keep this in mind. Naloxone is an antagonist for the opioid. And keeping that in mind here is that when we'll go to peripheral nerve, you'll see that opioids will produce peripheral nerve effects on the peripheral nerves, but those effects are not reversible by naloxone, which is interesting because most of other opioid effects can be reversed by naloxone. So mesencephalic periaqueductal gray matter region is what we're going to take as an example for how opioids work in the supraspinal area. So in this slide here, what we would like to understand is what are the areas, what is this PAG area, mesencephalic PAG? Number two, what is the effect of opioids in this area? Then we would see in the next slide, what is the overall effect of this area with the remaining nervous system? So periaqueductal matter, so inside the mesencephalon, midbrain, we have the central canal, right? So we call it cerebral aqueduct or cerebral central canal. Around that central canal, around that aqueduct, we have gray matter. That gray matter is called periaqueductal gray matter or PAG. In this gray matter, so please pay attention to this one, you would actually enjoy it. In this gray matter, here, there are neurons within the gray matter that are GABAergic. That means they release GABA on their neurotransmitters, and these neurons are tonically active. They're continuously active. So imagine mesencephalon, imagine the central canal of the mesencephalon, imagine the gray matter around that, and then imagine in that gray matter tiny neurons that are just active. Just like we have so many other neurons in our body and tissues in our body that are automatic, that continue to work. For example, our heart is automatic and the nervous system of the heart is automatic. Similarly, here we have a tonic activity of these GABAergic neurons. So the question is, so what? So let's look at it for a second. We are going to look at this action in two ways: when opioids are not present and when opioids are present. So when opioids are not present or enkephalines are not present in our system, what happens is, this is the GABAergic neuron, this tiny neuron, this is the end of it. This is tonically active. What happens is, of course, it releases GABA, as we're saying this is a GABAergic neuron. When it releases GABA, that GABA will then be acting on the postsynaptic terminal or on the next neuron. And GABA is an inhibitory system neurotransmitter. So the result will be the next neuron on which it is continuously pouring, that neuron will become inhibited. So I want to leave a seed in your mind that what is the function of this neuron? It will become handy in a second. But right now, just have this curiosity that there is a neuron or neuronal system that is continuously blocked or inhibited by the GABAergic neurons in PAG, periaqueductal gray matter. Now, when opioids are present in the system, then what happens is, I'm going to go here to show the same system, but in the presence of opioids. So let's look at it. Again, the same neuron, this tiny neuron is over here. This is the end of it. There is the mu receptor for opioid, mu or mu receptor. This little red thing represents opioid. So when opioids are present, they act on the opioid mu receptors, which cause the calcium channel to become blocked. Remember, we have already discussed this a few lectures ago, that primary effect through the mu receptors is that calcium channels are blocked. So calcium entry inside the nerve terminals, for example, or nerve cell bodies, that reduces. And that causes reduction in neurotransmitter release because calcium is necessary for the neurotransmitter to be released. And we have done that discussion in detail earlier. So this was a GABA system that was releasing GABA on the next neuron. The next neuron was then becoming inhibited. Now we have opioid in the system that work on the opioid receptor, presynaptic terminal, that causes calcium channels to be closed or not function as efficiently. Result is GABA release is reduced or stopped. So when there is no GABA, remember GABA was inhibitory and it was continuously active. When there is no GABA, what will happen to this one? The next one. The next one now will become disinhibited. It will become activated. It always wanted to be activated. This is like a tiny child who wanted to run around and do things, and you're holding the child and not letting them run around. And if you release that child, they're going to start running around. That is what is happening here. This neuron wanted to be active, and we have a tonic neurotransmitter GABA being poured on it or on its dendrites. The end result is this was inhibited. Now this has become disinhibited. It has become active. So now once again, the same question, what is really the function of this neuron? What will happen when we have given opioid and this neuron has become active? It has become disinhibited because opioid have reduced the GABA release. So generally, what are the topic we're talking about? We're talking about analgesia. So this mechanism must have something to do with pain killing. So let's see. So here is the complete circuit now. Normal circuit without opioids. We have the PAG neurons tonically active that cause from the periaqueductal gray matter to, we call these neurons here, the one that are going to medulla, we call them medullopital neurons. They are just like centripetal or centrifugal neurons. These are medullopital neurons. These are neurons that are going towards medulla. Why do we say that? From this periaqueductal gray matter, the neurons actually go to forebrain, they go to the limbic system. So this system affects our personality and it affects our emotions as well. I have just not drawn them over here because I just wanted to talk about analgesic effect. So usually we would say that the neuron from here go towards the cortex, that will be corticopital, and they go towards the limbic system, limbopital, and they go towards the medulla as well, that will be medullopital neurons. So here, these neurons end up in medulla. We talked about it last time that in medulla, near the respiratory center, there is the medullospinal tract, which would be from the medulla towards the spinal cord. So this is the higher center, being medulla, affecting the spinal cord, the gray matter of the spinal cord. So what would happen here is that these fibers will end up on the dorsal horn of the spinal cord. This is really important concept to capture. So here we have the spinal cord. This is the gray matter of the spinal cord, correct? So if I just looked at one side of this gray matter, we have the ventral horn and we have dorsal horn. And the most dorsal part of the, or most superficial part of the dorsal horn is called substantia gelatinosa. That is where the sensory nerves or the C fibers, for example, they would come and relay there. We have had this discussion at length again and again previously. So this red neuron is a sensory neuron that comes and relays in the substantia gelatinosa, normally the first layer and fourth and fifth layer. Then there are some internuncial neurons as well. Then there are second order neurons that will cross to the opposite side and then make spinothalamic tract for the sensory relay. We have done that as the first chapter, first talk in this series. In that talk, I remember I had mentioned higher centers modulating the pain. Today, we are talking about these higher centers. So this medullospinal tract, when these fibers arrive down here, what they do is they release norepinephrine and 5-hydroxytryptamine or serotonin. So these are norepinephrine releasing and serotonin releasing fibers coming from medulla, ending on the dorsal horn of the spinal cord, especially near the substantia gelatinosa or the superficial part where sensory nerves are relaying. Which sensory nerve? The pain nerve especially are relaying there. Now, normally, without opioids, what we do is we keep this system disinhibited. We keep it from working. We keep it stopped. How do we keep this system stopped? Because there is this little tonically active GABAergic neurons that are stopping this first neuron. When this is stopped, then this is stopped, then no effect here. When there is no effect at the spinal cord, the upper center is not doing anything or doing less, then the sensory nerve C fibers, for example, for pain, are just sending the pain signal, which are continuing to the higher centers. So that is happening and we are feeling pain as we usually do. Now, let's say there is opioid in the system. Now what is going to happen? So when we have opioid in the system, as I said before, this part is where the GABA release will reduce or stop. When that would happen, this lower center will become, or lower neurons will become disinhibited. When they are disinhibited, this medullospinal cord tract would start becoming active. And what will this do? It would release here, it would release norepinephrine and 5-hydroxytryptamine. That release will cause the dorsal horn of the spinal cord to become stabilized, less excited. And that would mean that the pain signals that are passing from here, they would pass with less intensity. Because in this area, we are now causing a suppressive effect. Now remember, we know this, that opioid can actually directly work on the neurons in this dorsal horn here and also cause stabilization, and the resting membrane potential is increased. So that would cause the nerve cell to become more stable and less excitable. We know about that, correct? Here, what we're talking about is it is not opioid directly acting here. We'll see that next. It is the higher center modulating this area of the spinal cord, reducing the excitation over here by releasing norepinephrine and 5-hydroxytryptamine. So if somebody said to you that how do opioids creates central effect for analgesia, then there are many answers. For example, there are actually central effect within the nervous system, within this brain, which would cause the analgesics feeling to be produced. However, this is higher centers modulated by opioid, which are causing the spinal cord dorsal horn to become less excitable not through opioid directly here, but through release of norepinephrine and 5-hydroxytryptamine, which in turn causes this dorsal horn to become stabilized, which then causes the pain signals to pass from here with less frequency. So is this clear? What happened with opioids? Opioid caused this particular neuron to not excite this neuron, which this excitation was actually to inhibit the remaining system. I shouldn't say excite. Opioid caused GABA to be released, that inhibited this one, and then the whole system stayed inhibited. When you give opioid, then the GABA release reduces and the whole system becomes disinhibited. The end result is that the dorsal horn of the spinal cord becomes more stable. Dorsal horn of the spinal cord kind of becomes inhibited. I shouldn't use that term. It becomes hyper, what is that? The resting membrane potential increases. And that is done by norepinephrine and 5-hydroxytryptamine. So that is the higher center analgesic effect of opioid, or supraspinal effect of opioid. The spinal effect. This is an effect that we have seen before as well. This was the very first chapter of this series, the spinothalamic tract. I'm just going to quickly review that. So this is again happening here in the dorsal horn. So what happens is that the peripheral nerve, in case of pain, the C fibers, there are, of course, the faster fibers as well, but C fibers, let's say, they're bringing in their impulse all the way into the dorsal horn, substantia gelatinosa, very superficial surface of the dorsal horn. Here is that primary C fiber coming in. We know that the mu receptors are present on the presynaptic. So this is the synapse, correct? On the presynaptic terminal and postsynaptic terminal. Or in this case, we'll say first order neuron and possibly second order. Why did I say possibly second order? Because it is possible that the interneurons are involved as well. So the first neuron comes in, then there is an interneuron, and then second order. So whichever order. But presynaptic terminal and postsynaptic terminal. We know that when the opioids are attached to their mu receptors on the presynaptic terminal, then the calcium channels will become blocked. When the calcium channels are blocked, then there is less calcium present inside. And even when there is an impulse that comes in and that wants the neurotransmitter to be released, the problem is calcium channels are blocked, so neurotransmitter cannot be released easily. So impulses are coming in. Let's say pain is being felt somewhere, but it is crashing here and dying. Why? Because opioid cause calcium channels to be blocked and the neurotransmission is not occurring. So when the neurotransmission is not occurring, of course, the chemical part of the nerve signal that passes through the synapse isn't working correctly, isn't working or working with less intensity. Then on the postsynaptic nerve, let's call it the second order neuron, we also have opioid receptors. Here, when the opioid bind with their receptors, here the inward rectifying potassium channels open up. We have done this discussion before as well. These potassium channels would cause potassium to exit from the cell. When the potassium is exited from the cell, then what would happen is that this nerve here will become hyperpolarized. Why? Because the potassium has gone out, inside is more negative now. If it is more negative, then reaching the threshold will become more of a problem. So this nerve, even if you, let's say that opioids are not working here for a second. So the nerve impulse reached here from some painful area. It reached here, it went into the chemical mode, that is the whatever transmission occurred here, and that chemical transmitter is now working here. For example, let's say substance P. However, this post-synaptic neuron or the second order neuron is now hyperpolarized. It is not responding to the neurotransmitter quite well. It is not developing an action potential because potassium has gone out. Because we did this discussion before, because let's say minus 70 millivolt is the threshold, and let's say the normal resting potential is minus 90 millivolt. Under the opioids effect, as the potassium goes out, the positivity goes out, this minus 90, let's say, becomes minus 110 millivolts. I'm just making up numbers to explain this. So as it becomes minus 10, now going from minus 10 to minus 70 to develop the action potential is more difficult compared to going from minus 90 to minus 70. That's what opioid did. Now we'll say that this nerve is hyperpolarized. We'll say this nerve has become stabilized. We'll say this nerve has become less excitable. So even when the impulses are reaching here through electrical and then chemical signal, this nerve is still not working very well. And the person would feel analgesia or pain killing. So this is the spinal one. I'm not spending too much time on the spinal one because we have done this in detail before. However, I want to connect an important dot of the supraspinal and spinal, and that is the supraspinal part here. That part is releasing norepinephrine and serotonin. Norepinephrine and serotonin that also cause hyperpolarization here, that also reduces excitability here, that also stabilizes these neurons here. So opioids are directly working here, plus opioids are working indirectly through the supraspinal system, again on these neurons in the spinal cord dorsal horn. I hope this is clear. So this is a spinal effect. The last effect for today is the peripheral effect. So this is an effect which is not very much clear to us. What is that? Is we know that if opioids in high concentrations are applied to the peripheral nerves, then an anesthetic-like effect in that region where it is applied develops. Exactly what is the mechanism is not known. And this effect is not reversed by naloxone. So that means possibly it is not related to mu receptors. When we say that we do not know the mechanism, we do not know it is mu receptor or not. But the mu receptor respond to naloxone by reversing. So it is an antagonist. The opioids are agonist to mu receptor and naloxone is an antagonist. Naloxone seem to be not able to reverse this effect. So what exactly is happening here, not known. Now, the second important area in the peripheral effect of opioids is where there is an active inflammation. So imagine some part of the skin or tissue is injured and there is inflammation and there is pain over there. Why is pain over there? We have done that at length, that how those pain fibers will send the signal and then the nerve terminal itself would release CGRP and substance P that would activate the local immune system cells, which would cause local inflammation. So now we have inflammation because of the injury and acidity and all of those factors. Plus we have inflammation even further exaggerated because of the substance P and CGRP releases. We've done that in those discussions in detail. Now the interesting thing is here. If we have an area like that, inflamed area, where the nerve thresholds are exaggerated. Now I'm using this term exaggerated from the book. In my opinion, the thresholds are actually not exaggerated. Exaggeration will mean that threshold is kind of moved up. But what they mean by threshold exaggeration is that the nerve cell has become hyperpolarized. So the threshold has moved farther away. So it is exaggerated, but it is still standing at whatever the threshold level is, let's say minus 70 millivolts. So we are in the inflamed state. We give opioid here, local opioid. And somehow this inflammation and the pain from here, the nerve thresholds start becoming normalized. The nerve becomes less excitable. And that is where exaggerated thresholds actually means less excitable. But in the book, they use the word exaggerated threshold to see more excitable. So here is an area of inflammation where the nerve is more excitable. I'm just not going to use exaggerated, kind of confuses. Here is an area of the inflammation where the nerve is more excitable. And if we give opioids over here, the nerve becomes less excitable, nerve endings. The question is how? We don't know. We do not know that if it is the nerves, opioids effect on the nerve ending somehow, or if it is the opioids effect on the immune system, because we know that there are opioid receptors on the immune cells, or if it is both. We are not clear. So how do opioids, when given in local inflamed tissue, help that tissue have a reduced feeling of pain, have that person have a reduced feeling of pain in that tissue is not really known. But the two possibilities are the nerve endings and the effect of opioid on it, or the immune cells or the immune cells and the effect of opioids on that. This is it. This is the discussion today. So I'm going to now very quickly just repeat this with three mechanisms. This is the analgesic effect. We're not talking about the reward effect. We'll discuss that next time. Then the time after, we'll discuss about the respiratory effect of the opioid, especially the respiratory depression caused by opioid and what is the mechanism for that. So the emotional part, reward part, respiratory depression and activity of the respiratory system, that we'll do later on. I have left that all out. Just purely analgesic effect of opioid. There are three areas or three levels where it works. Supraspinal, that is brain tissue. Many parts of the tissues have opioids working on them. However, the most characteristic is the periaqueductal, mesencephalic periaqueductal gray matter, and that effect over there. GABAergic neurons are tonically active, which are blocked by opioids, which cause the medullospinal tract to become disinhibited. When that tract becomes disinhibited, it releases norepinephrine and 5-hydroxytryptamine on the spinal dorsal horn, which causes the dorsal horn to become stable, less excitable, and the pain signals would have difficulty passing through that. Then is the spinal cord level. So this was supraspinal. Then is the spinal level. That is where we have already done this, that there are mu receptors on the presynaptic and mu receptors on the postsynaptic membranes. When the presynaptic membrane has opioid agonist on that, that causes less calcium channels to be open, that causes less neurotransmission, neurotransmitters to be released, and the pain signals transmit less. Is similarly, the postsynaptic membrane has mu receptors on that as well. When they are activated, they cause inward rectifying potassium channels to become open. Potassium gets out of the cell, that causes hyperpolarization of the cell becomes stable, less excitable, and the pain signals find it difficult to pass through these cells. That is spinal. And the third one is peripheral. Peripheral is divided into two. We know that opioid can be applied to the peripheral nerve and it produces local anesthetic effect. What is the mechanism? Not clear. Secondly, if there is an inflamed area and you apply opioids over there locally, not through administration, systemic administration, then it causes the pain to reduce and inflammation to be reduced. The question is, how is that done? We are not clear. Is it their effect, opioids effect on the immune cells and or their effect on the nerve ending? Not very clear, but the result is known that the local pain thresholds become more normalized.